Alright everyone, thanks for coming this morning. Today I'll be telling you about nerve entrapment in the upper limb. So, just an overview. I'm going to give you an overview, and then we'll talk about kind of the different nerves or where it happens. Nerve entrapment happens in the upper limb. Talk about the principles of treatment options, and then we'll kind of get a bit more specific as we go through the 101 different nerve entrapments. And we'll briefly talk about double crush at the end. So nerve entrapment was first described by Sir Astley Cooper, probably in 1920. And Sir James Paget in the 1850s was talking about a symptom which we now call carpal tunnel syndrome. So this has been recognized for a long time in medical terms, but obviously in the history of humanity for not that long. Now, we've only really been doing operations on these for the last 100 years or so. But certainly it's a recognized problem. And so what is a nerve entrapment is when people present with some kind of neurological symptom, so pain, paresthesia, numbness, weakness, or loss of function that's restricted to only a specific area in a specific neurological pattern. So nerve entrapment in the upper limb follows along those nerve patterns that we know from the brachial plexus coming down and affecting specific muscles, specific dermatomes, and that's the way we kind of diagnose things. And the main problem people obviously present with is pain and inability to use their hands in particular, which, as you know, the hand is the most important part of the upper limb. And what is nerve entrapment? So it's a compression of a nerve as it passes through an osteoligamentous tunnel. So all of these nerve entrapments have a similarity of that they have something firm, something that's not mobile, such as bone, and then there's a limited space, a limited area that this nerve travels through, and part of that space is mobile, such as a ligament, or other firm soft tissue structures. And that results in specific, so if there's increased pressure or space-occupying lesion, or a commonality of all of these nerve entrapments is some kind of compressive force on the nerve. So something externally that's compressing, or repeated trauma, a slapping, a rubbing, or it can be an acute injury, such as, after a fractured distal radius or a bad fracture of the arm, you can get an increased swelling and increased pressure, such as in the carpal tunnel. So increased pedal in this osteoligamentous tunnel puts compression on the nerve, and that causes injury to starting off with the Schwann cells and the myelin sheath, and then can actually, if repetitive for long enough, can actually damage the axon itself. And that all of these things lead to loss of neuronal function, and that leads to the neurological symptoms. So these are all the different, or these aren't all of them, these are just some of the causes of nerve entrapment in the upper limb. As you can see, they're quite broad, and we won't go through all of them, but things to just know. So pregnancy can bring it on, diabetes, certainly there's a high incidence of nerve entrapment in diabetes. But basically any disease or any pathological process can cause a nerve entrapment symptom somewhere along the lines. So how do we diagnose a nerve entrapment? The key is really a clinical diagnosis using a good history, so trying to find out specifically what bothers them, and finding out that good history in a neurological pattern. Is it an ulnar nerve? Is it a median nerve? And then a good clinical examination, and that uses the principles. The mainstays are Tinel's test, so having a repetitive compression of that nerve, reproducing those symptoms, and then that can help you move along the course of a nerve from proximal to distal to try to find out where the actual lesion is, or doing other forms such as Phelan's test, or in thoracic outlet syndrome, other tests that exacerbate that compression of the nerve and reproduce the symptoms are the key to trying to specify exactly what level. And obviously, with regards to treatment, we need to know where the injury is. Otherwise, we won't be able to treat it effectively. So investigations, X-ray doesn't help us necessarily diagnose what is wrong, but it can help us rule out some simple things such as malunited fractures or heterotopic ossification, other kind of deformities that we know will be putting pressure on these osteoligamentous tunnels that can be useful in helping diagnose. Nerve conduction studies can certainly be helpful. So, a decrease in the nerve conduction speed, and if we can isolate a specific area, can help us find out exactly where this lesion is, and they can be quite useful. Biochemical studies looking for things such as diabetes and hypothyroidism. So it doesn't aid in us actually diagnosing the nerve entrapment, but helps us diagnose and treat maybe the cause of these nerve entrapments. And MRI, CT scans, other imaging modalities have a limited use and may be specific in specific nerve entrapments, trying to find the cause of why they're happening, but they're not particularly good at helping us diagnose the actual nerve entrapment. But they can be useful, obviously, in operative planning. The treatment principles are always try with non-operative treatment first and kind of rest, so prevent the patient from doing activities that exacerbate these things, resting them in a splint, in a cast, immobilizing the area and allowing the inflammation to settle down can help reduce these pressures in the tunnel and help reduce symptoms, and is very effective a lot of the time. Anti-inflammatory medications have also been shown to help reduce inflammation and hence reduce the amount of pressure in these tunnels. Lifestyle modifications and re-educating people in their ergonomics of what they do in a daily life, whether it's sleeping or how they work, how they sit at a desk, how they hold themselves, can be quite helpful in treating these nerve entrapments. And then once we get to operative management, we need to consider, are we going to decompress the nerve, so just decompress this tunnel, or we actually transpose the nerves? Do we take the nerve and move it somewhere else where it's less likely to have this ongoing compression? But both of those have their problems. So we'll move on to specific areas of the upper limb. I'll try to cover most of them, but in the essence of time we won't go through them all. So that's just going through your dermatomes, so anything along those lines helps you start thinking about which nerve is specifically being injured. So we'll start with the ulnar nerve, because it's my favorite. Sites of compression, it can start approximately at the thoracic outlet in the lower trunk. It can get compression. And then this is just at the elbow. So if we look here, the arcade of Struthers, there's an osteoligamentous tunnel. And then as we come in through here, the medial epicondyle can cause irritation or neuritis. And then here, this is the big culprit, the cubital tunnel. And that is the second most common nerve entrapment in the upper limb, is cubital tunnel syndrome of the ulnar nerve. And then FDP can cause it. The flexor pronator aponeurosis can bring it in. And then as we come into the hand, there's also Guyon's canal, which is ulnar tunnel syndrome, which is in the hand. So features of cubital tunnel, as I said, it's the second most common nerve entrapment in the upper limb. Is that sensation in the ulnar nerve distribution and weakening of the intrinsic muscles of the hand are much more common than having any flexor carpi ulnaris or FDP, flexor digitorum profundus symptoms. And that's because the sensory and the intrinsic neurons are more on the outside of the nerve, and the FCU and FDP neurons are central. So we find that with these compressive symptoms that the external nerves, the nerves close to the outside, are more likely to be affected. That's one of the features of cubital tunnel syndrome. The exact cause we're not really sure, but certainly people flexing with sleeping with a flexed elbow seems to bring it on. You can imagine sleeping up with your head under your pillow can exacerbate this thing. Treatment, some studies have shown that at least 50% of people are going to be well served and very happy with non-operative treatment. So anti-inflammatory medications, getting people to sleep with a night rest, so bracing the elbow in about 45 degrees of flexion and in a neutral position. And then within 2 weeks, people show a lot of improvement in those things. So then we have to get into the operative management. Decompression should probably be the mainstay of options. There was a JOS article in 2007, and their conclusion was that simple decompression of the cubital tunnel, going in and incising all of these ligaments and so decompressing the nerve, was very effective in most cases, and they felt that there was less trauma than transposing the nerve, so less soft tissue damage, and there's no difference in recurrence rates between the primary transposition as well as just decompression. So people do very well with just simple cubital tunnel decompression. There were some studies showing epicondylectomy, so you go through a big incision and actually do an osteectomy or the medial epicondyle, and that felt to relieve pressure through the cubital tunnel, release the distance that the nerve is traveling, and has been shown to have very, very good effects. Obviously, it's much more invasive, but studies have shown that they don't have any particular rubbing, or you always worry about bone pain after doing, pain coming from the medial epicondyle after the osteotomy. As well as there's no difference in really recurrence rates. And then transposition, there's putting it in through a muscular tunnel, so taking a bit of FCU and wrapping it around a tunnel so that you want to take the nerve, decompress the nerve, and then you move it anterior to the center rotation of the elbow, and then I felt that restricts, stops the returted stress cycle of pulling on that nerve, and then therefore alleviating the symptoms. Or you can also a submuscular, so take FCU off and then bring the nerve through what you've created, your own tunnel of the FCU tendon, and then reattach FCU underneath it. So one is using some of the muscle to create a tunnel, but one is putting in actually a submuscular. So an intramuscular transposition or a submuscular transposition. And they've both been shown to be effective. And I think where their role is in revision surgery. So people who have recurrence of their cubital tunnel symptoms after having a decompression, another decompression is not likely to be successful. And certainly JOS recommends doing a submuscular transposition. But as we know, with any surgery, revision surgery has much lower has higher recurrence rates and is not as successful as a well-done primary surgery. So Guyon's canal syndrome, moving into the hand, the ulnar nerve travels in front of the intercarpal ligament, and then it travels between the pisiform and the hook of the hamate through the piso-hamate ligament, and then that is a canal that we can obviously get a lot of compression. It's divided into 3 zones. So zone 1 is before the bifurcation of the nerve, and that is you're going to have motor as well as sensory symptoms. Zone 2 is when the compression is after the bifurcation, but in the deep motor branch. So you're going to get the intrinsic muscle weakness, and then zone 3 is the sensory branch. So the mainstay for that is obviously splinting. If that doesn't work and people don't do well, then we have to move on to a Guyon canal decompression. So that's an incision, a volar incision over the hand, and simply incising all of this, the ligament, and that decompresses the tunnel and does have good results. Moving on to median nerve, everyone must be familiar with carpal tunnel syndrome. I think we talked about it in the first day of medicine. So these are showing the three different patterns. So one is, so the carpal tunnel is that intercarpal ligament. There's 9 tendons that go through the intercarpal ligament as well as the median nerve. The median nerve is most anterior and superficial, and then so anything that increases the pressure as the nerve goes through that tunnel can bring on median nerve symptoms. The classic, this is what A here is the classic symptoms. They can get some pain moving up the arm. They get numbness and paresthesia. It can be reported in all of the fingers. but it has to be in at least 2 of them, and primarily the thumb, the index finger, and the long finger. B here is talking about probable carpal tunnel syndrome, and that's probably what we think of more classic, but in the literature it's described as a probable, that the thumb, the index, and the long finger pain, and then if it's in an ulnar nerve distribution, chances are it's not carpal tunnel syndrome. So the causes of carpal tunnel syndrome are an increase in pressure in the carpal tunnel, which is normally about 3 millimeters of mercury, and certainly anything above 30 millimeters of mercury can cause nerve damage. So in that area, something increasing that thing. So idiopathic, obviously we don't know what can cause it. It's very common, predominant in females. For some reason, females like to get nerve entrapment syndromes. There can be anatomic reasons. So, for example, you could have I've seen palmaris longus traveling through the carpal tunnel. So having something that's going to increase the amount of volume will increase the amount of pressure. So more things going through the same amount of volume increases the pressure in that tunnel, causing symptoms. So synovitis, ganglions, infection, a systemic symptom. So pregnancy is well known. It's very common in some reports up to 40% of pregnancies in the 3rd trimesters, and then it just resolves. They can't explain it. They don't exactly know why. Diabetes, renal failure, rheumatoid arthritis, so systemic causes that are bringing out carpal tunnel syndrome. And then the interesting one is work-related. So think of repeated use. There have been studies that show excessive flexion or extension can increase the pressure in the carpal tunnel, but as well as trying to actually scientifically prove, whether using a keyboard or things like that, the literature I read was not very conclusive that there's a direct relation between work-related and carpal tunnel syndrome. This becomes particularly interesting because if people are making work cover claims about their carpal tunnel syndrome, it's going to affect their outcome, and we just have to be prepared for that. So treatment, splinting, resting, trying to take the pressure off the nerve through extension can work. Medications, anti-inflammatories, lots of evidence that anti-inflammatories do have a work. Now B6, vitamin B6, is taken up by the nerves, and it is shown believed to have an effect, and certainly there was a lot of favor for it. Studies more recently, B6 in placebo trials, are maybe showing that it's not as effective as once thought, so it's going out of fashion. Systemic steroids has certainly been shown to work in carpal tunnel syndrome to decrease that inflammation and increase symptoms. And interesting is steroid injection, so actually injecting the carpal tunnel and trying not to inject the nerve at the same time, which is the big danger, has shown to decrease symptoms very, very shortly. And I'll get to it in a sec. And then carpal tunnel, obviously open versus endoscopic. That's the orthopedic debate. Depends where, especially in Australia, depends where you are. You're going to get a different treatment. And when I get my carpal tunnel, please do it open. I just want to talk about steroid injection. I was reading, there's one paper that was showing people who respond well to steroid injections into their carpal tunnel have been shown to have actually a better outcome with regards to surgery. So people who respond well, you take their pain away. That's a good predictive tool that if their symptoms continue and you do on surgery, you can expect a good result. So once they were showing 90 plus people who had positive results from steroids injection, then who went on to have an open carpal tunnel release, had excellent results, whereas only 50% of people who had these steroid injections with no effect went on to have. So that's quite interesting, that it's just a predictive tool. So this is going through, this is a 2-portal. You can have a 2-portal or a 1-portal endoscopic repair, and then just using your arthroscope for vision, and then using a series of different blades cutting the carpal tunnel under direct vision. Obviously, carpal tunnel, the concerns are, one is the recurrent motor branch. We need to be careful that that's not divided, as well as one of the most common injuries is to the superficial palmar branch, which comes off proximal to the carpal tunnel and then travels above it. So sometimes there's variations that can travel through the carpal tunnel. It can come out through the carpal tunnel. We have to be aware that that exists and that it is not. It does get injured from time to time. This is having a look at an open carpal tunnel along, the third ray, coming down to the flexor retinaculum or the intercarpal ligament and dividing that right onto the nerve, decompressing. They've done studies to show that repairing this has no effect on bowstringing of the flexor tendons. So we don't have to repair it, we just have to open it up. And the other important thing is to have a look in there. Is there something else? Is there a soft tissue tumor? Is there a ganglion? Is there some kind of synovitis that we can biopsy and find what is causing this? So you have to be aware that it's not everything's idiopathic. There can be other causes of carpal tunnel syndrome, and it's a prime time intraoperatively to have a look for it. So talking about open versus endoscopic, certainly endoscopic has been shown to have a quicker return to function, recovery time in a matter of 2 to 3 weeks, faster recovery. But there's a lot of studies that say the long-term outcomes, there's no difference. And I found one interesting trial, randomized control trial of 25 patients with bilateral carpal tunnel syndrome. They had one done open, one done endoscopically. And then there's no difference at 3 months between their symptoms, but there was a lower satisfaction in the endoscopic side because they had a 5% revision rate. So, but that's only one study with a small number. But certainly open versus endoscopic, they're pretty similar. And then here, as I was talking, there's a recent randomized control trial, 5 years ago, showing corticosteroids had better pain relief in the short term than surgical management. Obviously, that makes sense. There's no operative repair. But at a year, there was little different. At a year, the surgical arm had better function at a year, but they had a slower recovery, so you do better quickly. And then there was this other randomized trial that I just read the abstract, showed surgical group had better pain and function at 5 months, so a year, 5 months. Surgical, some of the problems, scar pain, pillar pain, people do have pain after these operations, and that's one of the concerns. Very sensitive. 25% of people will have some kind of pain syndrome after their carpal tunnel release, but the majority of these patients, it resolves within 3 months or so. And then I've also found this interesting, that there was no evidence that I could find that immobilization provides any benefit for long-term outcome. So I've seen a lot of people put them in casts after carpal tunnel till the wound heal. Does this make a difference? Not supported by the literature, but I don't have much experience in it myself. So other median nerve entrapments, just quickly going through anterior interosseous entrapment. So Achillo-Nevin syndrome, which is anterior osseous, comes off prior to the elbow joint. Can happen in hematoma or after supracondylar fractures, or if you put a K-wire in after a supracondylar fracture which I've done, you can get anterior interosseous nerve symptoms. So that's obvious, pronator quadratus, difficult to isolate, FDP to the index finger, FPL, symptoms along there. Pronator teres syndrome, as the median nerve goes through pronator teres, it can be constricted there. The difference there between cubital tunnel syndrome is that the palmar cutaneous branch is going to be affected, so you're going to get palmar symptoms, whereas in a pure carpal tunnel, you should only get it in the fingers. Right? It shouldn't be, because, as we said, the palmar branch comes off prior to the carpal tunnel in most patients. So, I've lost. So radial nerve, posterior interosseous nerve entrapment was first described in 1968 as a cause of sudden onset or increasing onset of weak extension of the fingers. It's related to fibrous arcata of Frosch which is where the radial nerve enters through supinator, the posterior interosseous nerve. I had a beautiful picture, and I'm sorry that I've lost it. So there's also the posterior interosseous nerve has no sensory cutaneous branches, but it does affect a lot of the extensors of the fingers, so weak extension is worth having a look. We're just going to keep. Radial nerve can get entrapped, obviously, along its whole course. It can happen in the axilla, along the spiral groove, or Waterberg syndrome is superficial radial nerve entrapment. These are very, very uncommon, not seen very regularly. Just things to think about. So obviously, if there's a pure radial sensory loss, then we need to start considering superficial radial nerve. Musculocutaneous nerve entrapment is very rare. Some cases started popping up in the literature around 1978. So if you have really weak supination, a bit of elbow flexion weakness, but a completely normal power deltoid and sensory loss in the lateral forearm, you need to start thinking of musculocutaneous nerve entrapment. Some good case reports that resting and mobilizing them from 8 up to 12 weeks has been shown to have very, very good effect. And then there's some small groups of people with the lateral cutaneous nerve of the forearm syndrome responding well to corticosteroid injections, bracing and decompression. So same principles, non-operative, and then start looking at decompressing. Suprascapular nerve entrapment is very rare cause of shoulder pain, but it needs to be excluded. Happens a lot in people who do overarm activities such as baseball players. It struck down former Australian tennis great Dominic Hannon, unfortunately. So the suprascapular nerve comes off the superior trunk of the brachial plexus, and then winds its way back, coming along with the suprascapular artery, and then traveling through the suprascapular notch, and then the spinoglenoid fossa, and then it innervates, obviously, supraspinatus and infraspinatus. It's the only nerve there. So it's a very tortuous course, as we can imagine, and especially in these areas, in these fossas where there's a ligament holding it down, traction injuries, it can cause weakness. It's quite marked. When you do see it, you'll see this wasting of both the supraspinatus and the infraspinatus. So best seen from behind in the shoulder, weakness of those muscles. It can also be caused, so besides these repetitive strain injuries, shoulder dislocations. I was reading one study that had done nerve conduction studies and showing that people with shoulder dislocations, anterior shoulder dislocations, had a 25% of these people had some form of nerve injury to the suprascapular nerve. So it's very, very common, probably under-recognized, under-treated. Obviously, it gets better. We don't need to treat these people. But shoulder dislocation, shoulder instability can lead to suprascapular nerve entrapment. So obviously, non-operative treatment should be managed. First, muscle strengthening, periscapular strengthening. In surgical management, it can be difficult because you have to try to find out where along this course is it actually being entrapped. Sometimes this is where MRI can be useful if there's some kind of lesion. A ganglion from the shoulder, from the glenohumeral joint, compressing it. You can see it's not far from the glenohumeral joint. Ganglion can come in, compress the nerve. That can be helpful. You can do it both open or endoscopic or orthoscopic releases coming through the posterior. So there's a lot of different treatment options there. So thoracic outlet syndrome, something that I'm learning a lot about, but still know nothing. So the thoracic outlet is here, as between the clavicle and the first rib is where the great vessels come out of obviously the thorax and enter into the upper limb. So here we have traveling through the subclavian artery, the subclavian vein, as well as the brachial plexus. Now, the majority of thoracic outlet syndrome, so can happen anywhere on this brachial plexus, can compress anything, but the lower trunk, which divides into the ulnar nerve, as well as sends off branches to the median nerve is is more inferior and right up against the first rib. So that it's that lower trunk that is main compression symptoms happen. So you can get median nerve symptoms, ulnar nerve symptoms, predominantly ulnar nerve symptoms, but it can be a mixed pattern. And then so that you get these symptoms down here in the arm, but the actual symptoms are coming here. And so what can cause it? Well, again, anything that's going to increase that pressure. An article back in 1918 was talking about, they reckon the main cause of thoracic outlet syndrome is because the vertebra grows faster than the scapula. So as you go, you can imagine the scapula, and then that drags the scapula down, and the scapula being firmly attached to the clavicle then brings these elements down and then compresses that amount of space. And obviously it happens in everyone. It's not really symptomatic in everyone, but it predisposes us to having this compression in the thoracic outlet. So anything that's going to cause the shoulder to droop down is then going to pull that clavicle down and start compressing that what is already narrow space. So that's why re-education in people's posture and ergonomics can be quite effective in relieving thoracic outlet syndrome. Or you can have a clavicle fracture, as another common, a malunited clavicle, a big bony lump, putting pressure on that tunnel. So, and then we also have here's pec minor, and then the interscalene muscles. These are all here putting some pressures on these nerves. So why is that important? Because that comes to our surgical management. We need to know what's there so that we can start releasing that pressures. So it's a spectrum of presentations. It can affect the artery, it can affect the vein, or certainly with our interest, it's these neurological functions causing loss of function in the upper limb. It affects mainly women, 3.5 to 1. It's not 100% clear why. Symptoms, ulnar nerve pattern, like I said, it can be mixed anywhere in the brachial plexus. And people tend to have difficulty working overhead, as you can imagine, again, as people put their hands above their heads, increasing that pressure through the thoracic outlet. So differing tests. Adson's test is when you have your arm in abduction, probably, and then you extend your neck and then rotate towards that arm, and then take a deep breath in, and that's putting those interscalene muscles under tension, increasing the thoracic pressure, again raising the ribs, putting pressure on that thoracic outlet. And if you feel for the pulse, and if you have a difference in pulse between when your arm's abducted to 30-40 degrees and when you perform Adson's test, if you lose the pulse or there's a weaker pulse, that's suggestive of a thoracic outlet syndrome. Wright's test is when you fully abduct the arm and then feeling the pulse if you lose pressure there. Eden's test is pulling down on the arms, and again trying to put pressure down on the clavicle and compress the thoracic outlet from above. And the overhead exercise test is when you put your hands above and start doing something along those lines, and then people will fatigue. As you can imagine, if you're increasing that pressure, you're reducing the blood supply as you do work, you fatigue much earlier if you don't have that blood supply. So these are, thoracic outlet syndrome is mainly a clinical diagnosis. But again, other studies, X-ray can be very, very effective nerve conduction studies. So physical therapy, obviously overhead working is only going to aggravate it, but focusing on things that elevate the scapula. Like I said, it's the scapula dragging that whole arm down and bringing the clavicle down. So trapezius, your rhomboids, your levator, scapulae, if you focus on increasing the strength of those muscles, you can then take pressure off the thoracic outlet. And then if it's not successful, we need to consider decompressing that. Now there's been a lot of different ways. So we can release the scalene muscles, we can take them out, we can resect some of the first rib. Another cause of thoracic outlet syndrome can be cervical ribs. You can remove those, a bit hairy. Pec major release. excising the clavicle, so releasing from above, or any combination of these things. Now, I couldn't find any particular one that is clearly better than another. Just like anything, when there's lots of different techniques described, no one's better. So it's going to be surgeon's preference and comfort about what they can do. So, and then finally, we'll just conclude with double crush syndrome. It happens when there's some kind of central or proximal nerve lesion, and then there's another lesion further down. That's called double crush syndrome, so when the nerve is being compressed at two different points. And there's some evidence to suggest if there's a proximal or central lesion, such as a radiculopathy, disc nerve root compression, people are at a higher risk of having another lesion down on that same nerve. Another example is diabetes. People with diabetic neuropathy do have a very high predisposition to other neurological injuries, particularly carpal tunnel syndrome. So that's double crush syndrome, and it's important to recognize, because if you're going to surgically manage these people, you need to decompress both areas if possible. Okay? So, conclusions. I've had a whirlwind experience. I hope you have as well. There's lots of nerve entrapments in the upper limb, so any nerve can be entrapped. So the clinical exam and the history are essential in trying to isolate the exact place where this compression is, so that you can focus your treatment onto that specific area. Non-operative treatment should be always tried first. Has very good results, and over 50% of people are going to respond very well to non-operative treatment. So that always has to be your mainstay of nerve entrapment. And surgical measures to release that pressure on the nerve are obviously the final thing, and there's lots of different options there. So, thank you.